Good afternoon, dear professors and colleagues. I'm Dr. Shaimaa Ibrahem. I'm going to present fast retinal imaging. First, OCT takes a cross-sectional structure of retinal layers and provides three types of scan: A scan along the optical axis, B scan along an X and Y plane, and C scan or MFAS along the Z and Y plane. Fast imaging provides a view similar to that seen on fundus photography and direct ophthalmoscopy, and this gives image appearance as if one slicing retinal layers parallel to its surface. Before interpretation of fast imagery, we have to be sure that we have correct segmentation slabs, and always we have to correlate that with P-scan or structural OCT. Here we show the normal appearance of fast imaging at the different segmentation slabs: superficial, deep, choriocapillaris, and outer retina. Now we are going to slice the retina into layers in order to detect the value of fast imaging in diagnosis of different retinal diseases. First, regarding superficial retina, we have epiretinal membrane. Here, line scan showing epiretinal membrane exerting tangential macular attraction and traction and macular edema. Here in the first image, we can detect epiretinal membrane in the form of radial line extending from the epicenter along the retinal folds. And the exact value is that we can detect also if there is a space between the membrane and the retinal surface, which may assess during the dissection site, which may assess in the planning for dissection site during the surgical removal of the membrane. This is vitreomacular attraction. In line scan shows focal vitreomacular attraction. On first image, we can delineate the area of vitreoretinal attachment and the parafoveal tangential traction. Here's the same patient after complete BVD with resolution, vitreomacular attraction, and restoration of the normal retinal architecture. On first image, also valuable in assessment of postoperative cases of vitreomacular attraction. Here, for example, a patient following postoperative vitrectomy with IL impeding and inverse diamond flap technique for a full thickness macular hole. We can detect here an online scan a depression which is limited to the retinal surface, or what is known as dissociated or optic nerve fiber layer or inner retinal dimpling. Here's on fast for the same patient. We can detect concentric dark spots corresponding to inner retinal dimpling. This dimpling reported to be as a result of minor trauma to molar cells, and it is reported also that it is not associated with decrease in visual acuity or affection of retinal function. When we move deeper with the slab towards the middle retinal layers, we have PAM, or paracentral acute middle maculopathy, which may occur as a result of ischemic insult affecting the inner and deep capillary plexuses, and may occur in isolation or following various retinal diseases like retinal venous occlusion, retinal arterial occlusion, and also retinal vasculitis. Here, for example, a patient with central retinal vein occlusion and upper temporal branch retinal artery occlusion. Here, a line scan for the same patient, we can detect PAM lesion in the form of hyperreflective band-like lesion involving outer plexiform inner nuclear layer. Here's on fast for the same patient. We can delineate PAM lesion in the form of hyperreflective material along the superior temporal retinal artery, giving arteriolar pattern of PAM. Three patterns of PAM have been explained by fast imaging: fern-like or perivenular, arteriolar, and the globular pattern. These patterns can explain the extent of ischemic insult affecting the retinal layers. And it also reported that the fern-like or perivenular pattern of PAM has a better visual prognosis than other patterns. Also, MFAS can be used for following up this patient. Here, a patient with perivenular pattern of PAM, and here's the same patient after resolution of PAM lesion on MFAS imaging with resultant thinning of inner nuclear layer in the spectral domain OCT. When we move further deep with the slab towards the outer retinal layer, we have CSR. The value of MFAS imaging in CSR is the detection of size and location of serous detachment, and also presence of thickened fibrinoid fluid, also present size and number of PEDs, and choroidal thickening. Here, for example, a patient with active CSR, we can detect in the line scan neurosensory detachment, and we have a hyporeflective material in fast imaging corresponding to neurosensory detachment. Here, a patient with chronic CSR and subretinal fibrinoid deposit, on fast we can detect hyperreflective material. When we go further deep with the slab in the same patient, we can detect Becky vessels associated with CSR. Also, fast image can be used for following up this patient. Here, for example, has a patient with CSR with minimal fluid, a slightly enlargement of the fluid, marked enlargement, and then the fluid started to resolve. What about MACTEL? MACTEL can be diagnosed by several imaging modalities, but the value of fast imaging in MACTEL cases is the diagnosis of inner segment, outer segment break. And it is also reported that fast can be used for monitoring those patients and also assessing the prognosis. Here, for example, a patient with MACTEL, we have a line scan showing the disruptive photoreceptor layer, and we can detect also that the slab involving the photoreceptor layer. We can detect the fast image a dark spot corresponding to inner segment, outer segment break. Here, another patient with MACTEL, we can detect hyporeflective dots here in on-fast imaging corresponding to hyperreflective granule on line scan. And we also can delineate right-angled retinal venules dipping towards the deeper retinal surface. Multiple evanescent white dot syndrome. The value of on-fast imaging in multiple evanescent white dot syndrome is the diagnosis of the exact pathology or site of pathology. Previously, it was considered that the primary site is the choriocapillaris, but by on-fast image we can delineate that there is disruption. There is disruption of the outer ellipsoid zone and the interdigitation zone, which can be detected on fast imaging as a hyporeflective localized lesions. When we go further deep towards RPE, we have dry type AMD. Regarding reticular pseudo-drusen, which is a particular type of drusen found in AMD, and this is associated with progression to CNV and geographical atrophy. Here, line scan showing reticular pseudo-drusen, and on fast imaging we can delineate the extent of reticular pseudo-drusen with a simple image without a need for multiple line scans. Geographical atrophy. Geographical atrophy is the end stage of dry type AMD, and it progresses slowly over time. Geographical atrophy usually diagnosed by colored photo and fundus autofluorescence. Geographical atrophy can also be diagnosed by on-fast image, and it is reported that on-fast image at the level of inner segment, outer segment can be used as a useful indicator for visual acuity and also a predictor for the extent of progression to geographical atrophy. And it is also reported that on-fast imaging in cases of geographical atrophy is comparable to both near infrared and also blue light fundus autofluorescence. What about outer retinal tepulation? Outer retinal tepulation is diagnosed in various diseases associated with RPE atrophy, and it has a poor visual prognosis and may be misdiagnosed as intraretinal or subretinal fluid. Its diagnosis is very important to avoid unnecessary treatment. Here, a patient with chronic CNV, and we have outer retinal tepulation in the line scan. On the first, we can delineate clearly the outer retinal tepulation in the form of hyperreflective band around hyperreflective core taking the shape of tubes. When we go further deep with the slab, we have PCV. PCV characterized by polypoidal neovascular region connecting to branching vascular network. PCV usually diagnosed by ICG. OCT can add in the diagnosis of PCV in the form of double layer sign, multiple PEDs, and also we can delineate polyps here, which can be detected very clearly by on-fast image. And we can delineate also that the slab here involving the underneath surface of the RPE. On-fast imaging can also be valuable in diagnosis and follow-up post-traumatic cases. Here, for example, a patient with trauma and choroidal rupture and subretinal hemorrhage. We can delineate here the extent of choroidal rupture very clearly in on-fast imaging. My take-home messages. The real advantage of on-fast is the ability to slice and dice the images from the choroid to the vitreous. On-fast imaging can assist in the diagnosis and also follow-up of several retinal diseases. Always consider contour, thickness, and location of on-fast lab while interpreting on-fast images. Multimodal imaging is always needed. Thanks a lot for all medical retina team in Watania Hospital, and thanks a lot for your attention.